You are listening to the global network of podcasters dedicated to the pharmacy profession. Welcome to the Pharmacy Podcast Network.
3, 2, 1.
Adverse drug reactions, or ADRs, are a serious issue in healthcare today. The pharmacist is the last line of defense to help prevent ADRs. A rising role of the pharmacist is the specialist who focuses on our children. Pediatric pharmacy ensures safe and effective drug use and optimal medication therapy outcomes in children up to 18 years of age. Currently, there are more than 1,450 board-certified pediatric pharmacy specialists, known as BPS. If you're interested in this expanding field of pharmacy, this podcast is for you. All right, everyone, let's give it up for our host.
You want to do, he wants us to say his blurb.
Okay.
Do you want to do what Justin does at the beginning, like, welcome to the
Yeah,
pediatric? Okay.
Yeah.
And then I'll do the intro, and then Patrick, you start.
Sure.
Perfect.
Okay,
And
and
then-
then go ahead.
During the podcast, do you want us to refer to you as Dr. Reeves or Patrick?
Oh, God, Patrick, please.
Okay.
Okay.
Yeah, you're peds, so that's why you're like, not doctor.
Yeah. And then I was going to even make it even worse by asking, is it Patrick or Pat? So you can tell.
Professionally, I am known as Pat, so
Okay.
if you say Pat Reeves, more people are going to understand who you're talking about, I think. It kills my mom, but Pat is what I go by. Only my mother and my wife call me Patrick.
I have a brother named Patrick, and I only call him Patrick when he's in trouble with me or annoying me.
Yeah.
But he is my best friend, so there you go.
That's awesome.
Okay, so we'll just leave like 5 seconds of silence so that the editors know where we're starting, and then we'll get going. Hello, how are you, everybody? Thank you so much for joining another episode of Pediatric Pharmacy in Review on the Pharmacy Podcast Network. My name is Jenna Quinn, and I'm going to be your host today alongside the fabulous Miss Mary Baum. Hi, Mary.
Jenna, always a pleasure. I was telling our guests, Dr. Reeves, that it might be a wild ride because this is actually our first podcast without Justin. So thank you everyone for joining. Today we have Dr. Pat Reeves, who's a triple board certified general pediatrician. He's also an obesity medicine specialist and a pediatric GI that works in advanced virtual care and research skills and patient education in the management of children and young adults with medical complexity. Dr. Reeves is also the CEO of a consulting firm. So he is the CEO of his own company, which is pretty cool for us to see, of the Wild Child Medicine PLLC. He also has a specific research focus on the development of mobile health technology called the Clinical Action Plans, which provides automated clinical decision support to medical teams. And he also serves low health literacy plans for the home management of kids with chronic needs. As part of today's podcast, Dr. Reeves will cover some of his clinical action plans and the information that is presented herein with regards to the clinical action plans constitutes the intellectual property of Dr. Reeves. As such, these concepts and presentation are not to be shared outside of the agreed entities. So what is said in this podcast stays in this podcast, please, everyone. And if you didn't have a resume as long as Dr. Reeves, it's probably even longer than you thought it was. Dr. Reeves is also a major in the U.S. Army, which is super cool. He's actually, I don't even know how many titles he has at this point, but the opinions expressed by Dr. Reeves are his own, and the comments on this podcast do not reflect the opinions or positions of the U.S. government, the Department of Defense, or the Defense Health Agency. So everyone, please welcome Dr. Pat Reeves.
Mary and Jenna, thank you so much for having me on the podcast. I'm really excited to talk to you about some of the things that our team's developed and what we can do to perfect the way that we provide medicine to our most vulnerable population in this country, and that's children.
Thank you so much. I am dumbfounded by your resume, and it truly makes me feel extremely lazy. So Thank you. I'm really impressed by your accolades, and thank you so much for your service, Pat.
Thank you.
So I'm gonna get us started, and I'm gonna ask from one founder to another. What inspired you to start your company, the Wild Child Medicine? I'm always interested in other people's founder stories.
So mine, I would like to say, is like old Americana, I guess. I developed these clinical action plans that we'll talk about with some really great collaborators during the pandemic. And it's because I recognized in my own process and practice of caring for kids with complex needs that we couldn't see them in the hospital. We couldn't bring them into clinic like we were used to doing. And that's when we were forced to leverage virtual care. But there's a lot of things like how to weight-based dose drugs, how to communicate the dosing and frequency to parents, not to mention the complexity of gastric tube feeds and all of the other layers that go with that kind of care. It, for me, is impossible to do virtually without having that parent there to be able to see you do it, to draw it for them. So these clinical action plans became the solution I created and coded to meet that gap that I was providing. And the years went on, and we've published lots of different research, almost 12 different studies in total, randomized trials and so forth. And the emphasis was on improving the knowledge transfer, addressing health literacy, and it seemed like universally everybody loved it. And as a physician scientist, I was just going to leave it there. And then I started to get more and more interactions from colleagues around the country and actually across the pond to England and other places of the like. And my wife, shout out to my beautiful Nancy Reeves, who's a critical care physician assistant in town. She said, you know what, you should really, try and formalize this and give it structure and maybe do a company and call it something cool. And that was over dinner outside in our backyard with our kids around the table. And I was like, what should we call it? And my daughter came up with the idea. She said, I'm a wild child, so you should call it Wild Child. And I was like, we'll call it Wild Child Medicine. And then like my brand, which you can see. I
love that.
It's like zoo letters and stuff. My kids wrote my brand. And then I had a family member who's a graphic artist kind of tidy it up a little bit, and that's what it is. So my company is by and for my kids, and hopefully it's to serve to the betterment of care and really evolution of care for kids nationally.
So cool. So when you said that you coded this, is this like another part that you're adding to your resume that you like do you know how to code and do all of these rusting API things?
Yes, ma'am. So I mean, it's not I am by no means a back-end developer, but have you ever read the 4 Dummies series from Wiley? Like picked up a topic and said, I'm going to learn how to do this. So thankfully, the public library, so shout out for all the 4 Dummies. If you want to learn about diabetes and you're just a obesity medicine doc who wants to continue education, that's where you start. Anyhow, they have one for JavaScript. And so I pulled that from the library in 2020 and was like, okay, I have these cute tools, they have cute pictures. When I type the stuff out, the parents really like it, but I bet you I could code it so that I just do a couple of inputs and hit the button and it does everything for me. And guess what it does? And so I started that with Constipation, and then subsequently have about 15 different tools in production, all of which I've engineered to take the information from whatever societal guideline is meant to provide evidence-based medicine for that care, a lot of information from Lexicomp, and then I developed my own proprietary algorithms and injected that as JavaScript-oriented objects into these tools.
So cool. That's a lot of music to a pharmacist's ear, because you would be surprised, like, how many physicians don't use Lexicomp? Just that alone, I'm extremely impressed. And as a mother of 3, my story is definitely much for my kids as well. Pat, how many kids do you have? What are their ages?
I have 2. I have one that just turned 6 and one that will turn 8 right after Memorial Day.
Awesome. We're in the same phase of life over here.
Yes,
That is amazing. Mary, I'll pass it back over to you so I don't hog up all the time.
I'm super curious. Where can someone access these clinical action plans? Is it
So
like
it's
something
pretty
you
easy
subscribe
to
to?
Google. They're not really a subscription model. I'm in the process of finding teammates that we might take this to the next level. But currently, each diagnosis that has a plan is embedded into its own PDF file. And so they're essentially progressive web apps that are piggybacked into a PDF. And so for me, I use those in my day-to-day in all the hospitals that I work at. And it's simple because I can attach that action plan to my note. I can send it to parents through the patient portal because it's HIPAA secure. But I think the next step would be, partnering with a platform that has these embedded so that it is even fewer clicks to get the center of that safety Tootsie Pop.
That's awesome. So, what would you say were your biggest barriers to overcome when transitioning care from, seeing a patient live to then doing home disease management?
Yes, ma'am. So I think for me, it's the unknowns. It's the, if this happens, what should I do? And I have family members that are, good East Texas ranchers, even livestock auctioneers. So talking fast is something that's in my genes, but that isn't something that serves parents well doing virtual care. You can tell them everything that could happen at home over the phone or even during, a HIPAA platform secured virtual synchronous visit. But those words don't tend to have meaning. And there's also great literature to demonstrate that there is, quite frankly, a low percentage of knowledge points that parents take home, even from a live visit, and that they truly have comprehension of. And so that was sort of where the niche for the clinical action plans came up, because in pediatric medicine, the concept of asthma action plans has been out for decades. And really, the NHLBI, the American Academy of Pediatrics, and many other groups have really pushed forward the idea of using asthma action plans. There are a couple of other groups like Autism Speaks, the group out of Boston Children's years ago had come up with like some constipation protocols, but that diagnosis, constipation, makes up about 50% of what I and other peds gastroenterologists see nationally. And it's complex. It's more than just my child doesn't poop frequently enough. And there's a lot of sophisticated facets to that care that aren't easy to creating low health literacy elements in the form of pictures. I was able to show that, hey, in the green zone, your kid should be happy, or maybe they're in a little pain, or maybe they're doubled over in pain. And it is the progression of those symptoms that help parents to recognize that maybe I should go from this baseline maintenance dose of a laxative like Miralax and step up that to the higher doses recommended by Dr. Reeves. Or perhaps it's a child with more medical complexity, kids with severe spastic quadriplegia and cerebral palsy. Sometimes we're using stimulant bicocodal suppositories to help overcome that functional outlet obstruction of the colon, and they only need it once a month or so. So you don't have to slam them with meds day after day. It's just an as-needed option. And so developing the visuals was the first step in overcoming the barriers that I particularly faced in the pandemic. I think the funny part, though, Jenna, that I realized is when the pandemic went away and what we were left with was a lot of interesting things we had learned to do with virtual care during the pandemic, parents still wanted the virtual care. They didn't want to have to come in. They wanted to be able to just talk to me on the phone. Some of them wanted to do the virtual thing like a Zoom or Teams meeting, but most of the moms, they just want to talk on the phone. And if you have a clinical action plan like what I've developed, you are literally on the same sheet of music. They're looking at it at the same time as I am. We're talking it through. We're making sure it's working, or we're tinkering with it, because personalized functional medicine is the way to be successful and actually heal children from these sorts of ailments.
I love
On
that.
the same page. right?
Yeah, music to our ears, and I can tell you personally, and I share this openly. So one day my 8-year-old is going to be like, "What the hell, mom?" She's struggled with endoparesis and functional constipation now for 6 years, and so as a pharmacist, for me, having that experience of like being alongside the GI doctors and doing the clean outs and knowing what meds to grab and knowing the symptoms, I kind of took as, second nature. But it doesn't, again, some parents don't even notice until their kid's so impacted they have to go into the hospital. And so like, thank you, because even as a healthcare provider, when it's your own kid, it's still extremely overwhelming. And she would break out in hives. She would shake. She would cry. She would throw up. So it's like, it's so impactful when you have those visuals, because it really is overwhelming. And I'm sure you've talked to many parents, like the behavioral component of it that spins out of that is so stressful if you don't control it.
Absolutely.
So thank you for that. A little bit of I've gone through it, so I can understand how it can impact a family.
Absolutely.
And like you're saying, it waxes and wanes, and to empower a patient to be able, and a caregiver to be able to be like, all right, I'll give an extra dose of Senna, or I'll do this based off of the graphic, is like, think of where we're at. Like, think how much money you're saving healthcare dollars on this too, which is pretty insane.
Yes, ma'am. And there's other centers who have, since publication of my pictographic one, have published some research of their own homegrown action plan. And the interesting thing is, across the board for constipation, because again, that's what peds gastroenterology are spending a lot of time on, there's never been a study that says there's a negative impact of injecting this sort of care universally to the GI clinic, which is great. All it seems to do is great things. My plan specifically shows improved healthcare-related quality of life, improved comprehension, and then really improved health confidence. And it's from the very get-go. I hand you your plan in clinic, I walk you through how to use it, and you leave here feeling more confident that I can meet the needs of my child at home from day one. We have some great stuff from Nationwide Children's that showed that parents who were given the Pediatric Gastroenterology Service pager number and access to the emergency department used those resources less when they had a constipation action plan. Sort of, for me, that's an indirect validation that they were able to meet the needs of their child at home. And then we also have colleagues from Children's Hospital Philadelphia, which showed that by creating clinical decision support in the electronic health record in the form of a constipation action plan, that general pediatricians felt more confident using other things like stimulant laxatives, be that Senna, Bisacodyl, and others, to treat these patients rather than immediately referring the patient to peds gastro if Miralax didn't work.
I think that's like great too, because I feel like we should probably be rebranded to like Perfecting Poops, because I feel like Jen and I love talking about constipation all the time, and that's a huge topic that we end up talking to families about, and it's really because they don't understand what is what. So by like empowering them, like, this is your musher, this is your pusher, this is what's needed when the stools are hard, this is what's needed when you feel their belly is soft but they're just not pushing it out. Like, I think that empowers, and I feel like that saves a lot of healthcare dollars. So of all of these tools that you have between the clinical action plan and then also the pictures, what do you find the most effective?
It's probably going to be disease dependent. And I say that because probably the tool that I put the most hours into is my nutrition action plan. And so what that ends up doing is providing not just the same green, yellow, red stoplight motif for parents to understand, not just left and right safety rails, like if I'm the pediatrician and I'm ordering something like a proton pump inhibitor for an infant, you get an error message that said you should really rethink doing that.
Amen.
It also embeds all of the FDA-approved formulas, both for infants and for children and adults. Every single American Academy Nutrition Dietetics powdered formula mixing guide is included in the tool. So the hardest part for peds gastroenterologists and general pediatricians is, okay, my family brought in this formula, or they want to use this formula. What's the actual mixing guide beyond what's on the bottle? Because a lot of the time we add more scoops to do more calories per ounce. And there's hundreds of these, hundreds. And so my tool is instantaneous in selecting, okay, I want this formula, this flavor, and I want it at this caloric density. What's the actual mixing recipe? What's the displacement? And then it calculates everything for me. Okay, what have I said to the parent we're going to give them as far as nutrition, as far as free water, and so forth? And so it summarizes on a single sheet for me, what is this patient receiving? The fun part is, and it's probably why it took me so long to finish it, the backside is for parenteral nutrition infusions. And so this is my tool that was really designed to help assist my kids with short bowel syndrome. And so my greatest story is that I had a child with very complex disease and short bowel syndrome on parenteral nutrition. We did a Make-A-Wish thing. He went to Disney. He got sick at Disney World and had to be admitted to Children's Hospital, but he had his action plan. It had everything he had on there, down to the actual parental nutrition recipe that we were doing for him. I think it was through Quorum. Anyhow, what you ladies have probably experienced is that there's a delay in care. You can get to the ER, you can be admitted, but usually we don't have records for you. We have no idea what you've actually been on, and so we're just going to start what we think is safest, but it may not be ideal. But this kiddo, he went to that hospital, parents hand the pediatrician medical team the sheet, everything's ordered, seamless. And so for me, the biggest boon has been the idea that for functional gastrointestinal disorders, gut-brain interaction like constipation and coparesis, this tool can travel with you. I can sunset your care. You don't need to see me again, but if this happens, use it. And then also for very clinically complex kids with significant medical fragility, these tools can go beyond the market that they're in. They can cross regional lines where the electronic health record may not follow them, and they can still maintain continuity of care, even if establishing with a new acute care team.
That's amazing. To that point, like I feel like that's where we hope to shine as Perfecting Peds. That if we do two things. So obviously we are completely have an accurate picture of the patient's meds, but similar to you, we set them up with a MedRec tool, an adherence tool that we update, and then it pings to the parent's phone to remind them to take the med. But then also that same thing is that like it's very, when these parents have 20 or 30 medications, like you're saying, they show up to a hospital that's, in a different state. It's really hard to get the medications right on ER admission. Now, this is a very biased question. So what role do you think pharmacists can play in supporting home disease management?
Oh, surprise, surprise. I think there's an enormous gap in our healthcare system across the country that we do not team with pharmacists the way that we should. I think that there's just a great deal of knowledge that our medical providers, physicians, nurse practitioners, physician assistants lack. And right now, with provider shortages in our country, the idea to be a subject matter expert on everything is impossible. It is an uphill battle. But the problem is that even in my medical school at the University of Texas, we were not positioned in a way to actually team with pharmacists from the outset. My center here at Brooke Army Medical Center and also at University Hospital, I think follows a good model because the pharmacist is a text or a phone call away. They are rounding with the inpatient teams. And I think, thankfully, that has been to the betterment of pediatric care and the betterment of medicine in general over the last 5 to 10 years. But where is that pharmacist intimate presence in the outpatient setting? Because unless you're getting parental nutrition infusions, there's actually a low degree of touch points offered to pharmacists in our current care setting. And I don't like that, because there are always great ideas that I get from pharmacists, especially if we're in the setting of needing to consider prior authorizations. That teamwork makes the dream work as far as actioning care that children need. And I think that Perfecting Peds has discovered a solution to fill that void, which is really, really needed. But the question is, how do you expand that? How do you evolve it to have more touch times and increase the proportion at which there's a pharmacist who's actually almost like the primary care pharmacist for these children with medical complexity?
You want to be our spokesperson?
I know. Can we hire you?
I'm a believer.
We speak the same language. It's funny because like Jenna and I also have all of these care plans that we come up with, and it's like she's in Jersey and I'm here in Miami, but when we met, we're like, we speak the same language. Oh my gosh, we do a lot of the same practices. So like we're joining our brains together to make these like clinical algorithms as well for our patients. So it's like we are literally echoing the same things. Constipation is another big one that we have and that we like have created a care plan for. But in your opinion, apart from constipation, what other chronic diseases do you feel also benefit from these clinical action plans?
I think probably my children with tube feeds, that's probably the number one where I've made the best impact. Two other tools that seem to be very frequently employed here in our center to a lot of improvement of care is we have one for cystic fibrosis. And you can imagine, even with modulation therapy, I was the Cystic Fibrosis Center director here for several years at a fellowship. Even with CFTR modulation therapy, you've got pancreatic enzyme replacement therapy, a lot of acid suppression, a lot of nutrition supplements and vitamins, nutraceuticals, a lot of behavior meds, airway clearance, and it just goes on and on. And so that has also been one that we published in Pediatric Pulmonology years ago that we're still using to this day, where it summarizes everything for them. It tells them what does this medicine actually do and why, and helps to leverage some things. As sort of the pancreas doctor in that clinic who cares very much about growth and enzyme replacement therapy, one thing that we sort of challenge that is not necessarily always talked about in the cystic fibrosis world is, if you're supposed to take 2 enzyme capsules for every meal, and your meal is a sandwich with vegetables, but then you go and eat a large pizza, you should probably take more than 2 capsules. And we laugh, right? Because like we know that.
Right.
But that's not something that physicians are normally talking about. But guess what? On the basic backside, we always have a patient education sheet, and it clearly spells it out in both written word and pictographic forms, with a YouTube video also offered. And so for me, I felt like that was something new I could bring to the table, especially for the kids who might have poor growth related to their exocrine pancreatic insufficiency, because we ensured that their enzyme dosing was right on target, that they could acutely respond to higher fat intake, and that they weren't overdosed, putting them at risk for the fibrosing colonopathy.
I feel like I should exit this conversation and you and Mary could just jam, because what she didn't tell you about herself, did you tell him that you're a pediatric?
I didn't tell him anything, but I told him I was also like spaghetti. I was like, I'm just like you. I'm kind of just all over the place.
Well, she's a dietitian as well. So she is so she's my go-to when I'm like, Mary, oh my God, like how do I do X, Y, and Z? So you guys are speaking the same love languages. I can't even go close to any of the nutrition stuff. Pancreatic enzymes I can do, but like once they start asking about formula and K-cals and exactly like you're saying, I'm like, I'm so outside of my lane, like I can't do this. And pediatric dietitians aren't readily available like they think they would be. It's wild.
Not at all. And even in the country, if you actually look at the numbers, the physician shortage, we're doing pretty good. If you look at the actual dietitian shortage nationally, that's actually the even scarier thing, to be honest with you. Because if you go back to the core offerings of preventative medicine in the United States, part of that could be a bedrock foundation of preventative medicine is good dietary knowledge. It's not something that's really taught in most medical schools. And so you need registered dietitians, nutritionists there at the forefront, but they're not because we don't have enough. And
Yeah.
it's just
They all
another big
leave.
problem.
They
They
all
all-
leave for PA school.
Yeah.
That's like the
Or-
general trend. Every dietitian I've ever had, like on our rounding team, has left for PA school. We haven't been able to keep one for more than like a year and a half.
Yeah, yeah. And there's something to be said that, of course, like maybe physician training, like food as medicine and healthy living, maybe that should just become a part of basic training. But
Food as
that
medicine
doesn't
is my
really
jam.
happen. Yeah.
That's literally my favorite thing. Once we get started talking about food, I was like, "Oh, you want to treat all your ailments with food?" I'm like, "Let's go." So I one of my favorite things to do after a visit is I will make, especially if it's a picky eater, they need diabetes snacks, they need like low cholesterol things, or they're just super picky. I'm like, "Okay, let's work with what your child likes," and then I come up with like little ideas. So I'll make them like a personalized PDF of like, these are Pat's like pizza flavored protein snack. So it'd be like turkey sticks with like cheese and stuff. So it kind of simulates a pizza, and it's like what a lot of these like autistic picky eaters who have issues with texture like, but then it gives them like the right nutrition. So like I think every year I end up doing something on food as nutrition, but that is like the like key to my heart is just like fixing everything with food. I always tell people I'm the worst pharmacist. I'm like, I will never try to fix something with a medication. I always try to start with food because I feel like it's more benign and it's more of a lifestyle thing than anything. So we're speaking exactly the same language here.
I love that. No, that's definitely me, because you would think, like, as the tube feeding doctor, I just want to put feeding tubes into every kid, and I don't. And believe it or not, there's a modular product that is comprised of carbs and fats only, and it's something that we use very, very commonly in this country that I'm sure Mary has tons of experience with. But by God, I give a cupcake recipe that makes every cupcake 375 calories. You eat one a day, and I bet you'll grow and not need that stomach feeding tube.
Love that.
That's really cool.
So I think going on the opposite side of things, we talked tube feeding, constipation, CF. I think a big topic that just while we have you is obesity. That's something we deal with all the time. And the kids are getting like bigger and bigger. There's lots of questions on GLP-1 agonists. So what is your experience in your clinic, and how do you deal with it? Do you go straight to the GLP-1s, or do you try to do like a Topamax or something in the meantime, like a metformin?
It really is situationally dependent. So I am so fortunate because here in San Antonio for the military, we have the largest multidisciplinary healthy habits clinic in the world. And so it's run not just by me. We have a obesity medicine board certified peds endocrinologist. We have multiple adolescent medicine fellowship trained physicians that are also board certified in obesity medicine. And then we address the other huge needs. We have RDN on the team. We have a clinical psychologist on the team. And so that is first step. You certainly look at what the current lifestyle is and make those modifications and bring them back. But we have the ability to action that for this child who is, this was a referral I got last week, and I'm going to see this kid tomorrow. 17 years old, BMI 46. What do we do? Okay, well, we're going to need to have a really difficult conversation in the first visit. I'm going to call parents ahead of time and say, bring some tissues because there might be tears. We're going to talk about, hey, we're going to need to consider these medications that we have great efficacy data on. There is risk of side effects. We don't really have long-term safety data in children, but everything looks to be that it will help improve weight loss. But also, do we need to consider endoscopic bariatric procedures like placement of intragastric balloons? Do we need to consider sending you to the bariatric surgery team for something like sleeve gastrectomy or other similar surgical options to address obesity? The benefit, again, here is that we can do all of that in-house at one center, and we have enough teammates to provide the touch times that would follow the recommendations from the guidelines. So I would say that while those are still hard conversations, it's actually pretty easy clinical medicine. My harder time, what makes it all worth it, though, Mary, is my kids who are under the age of 12 that fall into that obesity category. because our multidisciplinary team is really set up for age 12 and above because it's primarily run by the adolescent medicine team. But who's going to care for the littles?
Yeah.
And so fortunately, we have a growing population in this respect so we've got the clinical experience, but we essentially have a general pediatrician who's board certified in lifestyle medicine. We have me, PGI with obesity, and then we have my peds endocrinologist. And between sort of our triad, our trinity, maybe I'll say, we do specifically care for our children under the age of 12 with obesity. Many of those children will have some sort of syndromic or atypical neurologic status. And so I have upwards of 20 or so kids under the age of 12 who are on some sort of GLP agonist, most of them on GLP-1 agonist therapy, and it is to treat their obesity, treat their hyperphagia, some of them with monogenic forms of obesity, which we've been able to prove with genetic analysis. And so those are really the easy ones. It's our kiddos who have trisomy 21 and hyperphagia, or severe autism spectrum disorder and hyperphagia that causes violent outbursts. Those are the harder ones to get the medicine approved for, but truthfully, it has been a huge success getting those kiddos onto GLP-1s, because not only do you see the positive metabolic effects of the weight loss, for those who are severely hyperphagic, who just never get satiated, the medicines help with that behavior, and then even the violence improves, and the dose of their atypical antipsychotics can tend to come down.
I love that. So one of our health plan contracts, Pat, is actually, they gave us 1,000 plus of their most obese patients. So like these kiddos are living in the most rural area with no access to anything. And I think people are often shocked that I'm so for GLP-1s, and then obviously, yes, you can use metformin if they have, concomitant diabetes, or Topamax is great if they have seizures or headaches, or like you're, kind of killing two birds with one stone. But we know the most efficacious is a GLP-1, and like people are horrified that at 8 years old I'm making this recommendation. But then you see the 20-year-old that you're also taking care of that's morbidly obese, that has all these behavioral issues. We've even seen a lot that have intracranial hypertension. Like, I mean, these things that, you're just like, if you could avoid all this, like, why wouldn't you,
Yeah.
And I think sometimes, like you're saying, if it's an autistic population, or we're focused on just the dietary component, sometimes that doesn't work for a patient, and sometimes they're more amenable to having the dietary conversations after they've, lost a few pounds. And I don't know what your take on that is, but that, I feel like.
Absolutely. No, I'm definitely on the same page, because that's part of the initial visit for me is, hey, these are the lifestyle changes that we're going to make. But I use the same metaphor as the discussion I have for parents starting GLP therapies for their child with obesity as I do for children who are failure to thrive, who probably need a feeding tube. So here's our feeding tube guideline. If that child is going to need a nasogastric tube for 6 weeks or more, that's probably the indication to put in a surgical gastrostomy feeding tube. Okay. So we talk about that, and I say, hey, do you think your child, who this is my first visit with them, if I put that nose tube in, do you think it's going to stay in for more than 6 weeks? Most of them, yeah. Do you think it's ever going to come out if I put it in? No, I don't think it's going to come out. Okay, so we have established then that it's going to take more than 6 weeks for this feeding tube to get your child's gut rehabilitated to where it needs to be to have autonomous intake of calories by mouth. Let's put the G tube in and avoid all the oral aversions that can come from chronic nasogastric tube usage. Done. That's easy. Order the surgery. The same principle, I think, lies with the use of GLP-1 agonists and similar hormonal therapies for obesity management in younger children. We talk about, do the GLP-1s address the root cause of obesity in these children? And let's say this is multifactorial obesity. Kid is very overweight, obese, and so are the parents. It's not genetic in the sense that there's one locus of leptin deficiency or so forth that we have. This is just our garden variety, natural over malnutrition. Okay, guys, do we think that if I enact lifestyle management options for your child and you for the next 6 months, that they're going to abide by that it's going to be realistic, and that they're going to lose weight? No. So at that point, I'm left wondering, okay, if I took a vow to do no harm to these children, but I'm just turfing this for 6 more months for something that's doomed for failure, why would I wait? And so that's sort of my perspective on that, because I would say that most parents, they recognize when their kid is excessively overweight or obese, and they've probably tried to make changes at home, and they've arrived already having failed that. And I don't personally think that it's right for us to be the ones who start the stopwatch on that. If aggressive efforts have already been made at home, perhaps in order to avoid the cardiovascular and endocrinologic metabolic side effects of obesity, maybe we should initiate this therapy sooner.
I see it more like a catalyst. I always tell them, I'm like, this is not by any means long term, but this could help make it easier. So like once your child like loses a bit of weight, it might be easier to play outside more. It might be easier to eat less, and it may be easier to to not have these issues with like aggressiveness and stuff. So it's like I never recommend it as a long term thing, but this can help just like make things a little bit easier at the start, and then we'll slowly take off.
Absolutely. And, I've been in this situation too many times to count, but as a liver doctor, we are referred to children who have elevated liver enzymes on blood screening, a lot of time before starting Topamax. And do these kids have what we used to call non-alcoholic fatty liver disease, now what we're calling metabolic associated fatty liver disease or steatohepatitis? So the question then is, okay, how much weight do you have to lose in order to resolve the inflammation in your liver? And it's not much, 8 to 10%. And so if we're talking about a child who is 200 pounds and 10 years old, you're talking 20 pounds or less. We don't mean you're going to go from 200 to 100. We're talking, 15 to 20 pounds. And certainly a GLP agonist should be able to help you accomplish that. And then at the same time, as we are changing your metabolic work, helping you to lose the weight, hopefully you're gaining confidence in the idea of our weight loss action plan, and you thereby derive buy-in from the dietary changes, the exercise initiatives, and all the other components of that weight loss action plan that we've helped you create.
That's amazing. I think it also puts into perspective. I think there's such a guilt as a parent for pulling the trigger on a lot of meds. So I love how you really equate it to, when we torture a kid, that's failure to thrive and not give them the nutrition they need. It's the same exact thing. We have similar conversations almost daily about children with ADHD or autism struggling with behavior that's so disadvantageous to themselves and their families, but yet the weight of starting a med, even an educated one, just like we're educating you on the side effects, we're monitoring you closely, et cetera, I think is one of the huge roles that providers really do need to fill. Knowing that as parents, Pat, there is unnecessary guilt for a lot of things as a parent. What advancements in pediatric hepatology and GI are you most excited for?
Oh gosh. Okay. So beyond the idea that now we have more therapies, both pharmacotherapy and sort of mechanical transcendental irrigation, we have things like Linzess, and we have things like prucalopride and other options that are becoming more widely available for children with motility disorders. So that's a huge win. But really the thing that has made the most impact on my practice is the chronic management of cholestatic pruritus in children, especially those with Alagille syndrome. And so the advent of these ileal bile acid transport inhibitors like maralixibat has just demolished the polypharmacy that I used to put these kids on to control their itching. And for me, it has made the landscape change as to when or ever am I going to need to refer you for liver transplant.
Wow.
The first thing I think of is ursodiol. So what you're teaching this? I'm like mind blowing. What was it that the name of it is a monoclonal
So
antibody?
it's Miralixabat. Its brand name is Livmarli, and it's sold by Miriam. Anyhow, it is an ileobile acid transport scavenger. So essentially, it is grabbing onto the extra bile that would normally be absorbed freely through the ileum, and you're going to poop that bile out. And so for cholestatic liver diseases, they've been able to show specifically that this kind of medicine is very beneficial. For Alagille syndrome, it's also been shown for progressive familial intrahepatic cholestasis, different PFICs, and they're working to see if it actually in clinical trials is beneficial for primary sclerosing cholangitis. But to sort of tell you what's been the practice for decades is that to control the itching related to those bile salts coming up through your skin, we would put kids on multiple antihistamines, 3 or 4 even. We would put them on, Atarax would be the sort of foundation of that, and they're always sleepy on the antihistamines, worsening behaviors, worsening school performance, sleep disturbances, and so forth. Ursodiol, like you said, Mary, is always the mainstay of that clinical plan as well. Then you would have to throw on other things. Rifampin was pretty typically, I guess, the last 20 years, the third line therapy we would add on. Has its own issues with KIP450 metabolism, side effects, right? And so no one really loved that. And then we would also, really the last 6 or 8 years, naltrexone scheduled has actually been shown to decrease cholestatic pruritic symptoms. And so we're throwing all this stuff at them, all of it. And it is incredible. You put these kids on these IBAT inhibitor therapies, and you slowly peel back the scary things like rifampin. You peel back the naltrexone, which frankly works amazingly, but if they don't need it, they don't need it. And, I could get kids down to maybe they're on an antihistamine, maybe just for like winter time when the aeroallergens change and your skin gets a little drier, maybe you're going to need that added antihistamine back in. But pretty much most of my kids now, they're on ursodiol because I just can't stop it. It's mostly my genetics. I just can't. And they're on the IBAT inhibitor.
That's amazing. And you're speaking music to our ears because, a lot of times with our patients, we're taking meds off instead of adding them. Mm-hmm. And so that is our main goal. How do we make this as convenient for the patient, the family, but most importantly, expose them to the least amount of drugs, least amount of side effects. And I think, honestly, some of the patients that we take care of are on the scariest GI meds, like erythromycin, Reglan, Bethanical, and a lot of times, their GI regimen isn't even optimized. So I love, your opinion on all that. We could do a whole nother topic on that, but I think
I've got time.
Seriously, because that is my biggest bugaboo, and these kids get left on these high risk drugs like Reglan. Sometimes, they say 3 months max, for years and years and years without reassessing is it needed or making other changes to compensate for that.
I cannot speak for my entire tribe nationally of pediatric gastroenterologists. I can't. But I use Reglan this much. And I will just tell you, the first time that you see a child that you gave tardive dyskinesia to because of Reglan, you're never going to use it again.
Yeah.
And so, every patient that I inherit from someone else, I just tell the parents, hey, that's not my vibe. I don't do Reglan. It is a Dr. Reeves black box warning, and I just won't.
Yeah.
And
I'm the same school.
Yeah, if you care that much about Reglan, I'll transfer your care. That's fine. But no, I just don't do Reglan.
Awesome.
Well, Dr. Reeves, Pat, I have a hard time ever calling people without the doctor, but Pat, thank you so much for joining us. I feel like we could talk to you forever. We definitely all speak the same language. So I feel like it would be worthwhile probably to invite you back for another podcast. But thank you so much for taking your time out and talking to us. You're an absolutely incredible human being.
Thank you so much for the opportunity, ladies. I can't thank you enough. Super enjoyable. Best part of my day.
Thank you, Pat. And then if any of our listeners wanted to connect with you or learn more about you, what's the best way to do that?
So if you Google Patrick Reeves Wild Child Medicine, that should come up. It's just a simple Google site for me, and there's a way to get in contact from there.
Awesome. Well, thank you again. We really appreciated our time with you, Pat.
Thank you so much, ladies. I'm going to sign off. Look forward to chatting again next time.
Thank you, guys.
Bye-bye.
That's all for today's episode. Thanks for listening, and remember to subscribe on Apple Podcasts and leave us a review.